get rid of this. I don't minimize the other thing. Okay.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, this is Gary Swartz, Associate Executive Director of the American Academy of Home Care Physicians. Thank you for joining your colleagues this afternoon in the Academy for this afternoon's webinar on clinical practice, preventive services, and securing practice revenue. I want to discuss existing and potential services and revenue, existing and potential clinical services, protecting your existing and future revenue, with particular emphasis with some of the activities and initiatives of the Academy in protecting your services and unburdening your practices from medical record review and providing a bit of a regulatory update. And then close by discussing the e-prescribing program incentive and adjustment so that you still have time to get those prescriptions accomplished or get the exemptions also accomplished. In the next slide, in terms of the Medicare fee schedule, now that we're underway this year with the SGR resolved for the balance of 2012, the 2012 conversion factor is a little bit more than $34, about a 1% increase from 2011 due to some minor update adjustments. The Academy will post the house call chart on the site now that this information in the SGR has gotten resolved. The SGR issue remains, as you know, for future years, but in an acknowledgement of the Academy's work and the potential of IAH. The Academy is meeting with the CMS Chief Actuary on April 5 to review the savings potential from IAH and the use of savings to fund, at least in part, solutions to the SGR issue in the years ahead. This is a very important development for the Academy and puts us in a good stead with policymakers on a bipartisan basis. So I want to turn to, based on inquiries to Academy staff about preventive services and what can be provided from a house call practice perspective. So I want to discuss the potential to add preventive services to your practice. Prior to doing that, however, I want to take a step back and have you consider who are your patients. Are they the multi-morbid frail elderly? What is the socioeconomic status? What are the choices and preferences of your patients and their families and caregivers? Is your patient population relatively younger, again, relatively speaking, a bit more financially comfortable, yet still home limited? Are they competent and alert, your patients? As you'll see, that's an element of some of the services to be rendered. Are you moving into the dual eligible population? Because some of the preventive and screening services may have more applicability to a dual eligible population than they do to a multi-morbid frail elderly population. And then overall, what clinical and ethical considerations are presented when considering the preventive services with your patient population? So what is the potential to add preventive services to your practice, and why add preventive services to one's house call practice? It formalizes the primary care clinician relationship. One of the things that we've found is that the carriers often want to take a look at that relationship between the house call practice and the patient as compared to other relationships. And one thing that the addition of preventive services would do would solidify that primary care relationship. Importantly, it provides better preventive services, will help you to provide better care as recognized by evidence-based proponent organizations, by Congress, and by CMS. Preventive services also may produce incremental revenue for your practice. This is something you do want to evaluate relative to the patient benefit, the cost and time, including the opportunity cost of your providing the services on a personal basis, or you're arranging the preventive services. Rendering, incorporating the services also is a part of good practice and satisfies the increasing realm of measures that are required to be reported to the Medicare program and through some of the bundled payment programs, and even perhaps in the IAH itself as the specs come as the the announcement of practices becomes known later this spring. And again, consider whether clinically and emotionally appropriate for your patients. What lessons have we learned and reinforcements and have been reinforced through our experience with preventive services? We've learned that house call sites of service are not written in nor written out in terms of site of service for preventive services. In a sense, house calls are a bit overlooked because, as you know, your services are rendered in lieu of an office visit, and as a result, the office setting is often described, or settings described where services would not be covered and paid, and so house calls are not explicitly mentioned, and so that reinforces the importance of your documentation of the medical necessity and why you're seeing the patient in their residence. Preventive services, however, are not restricted by congressional intent nor language to an office-able Medicare beneficiaries, and the Academy has advocated and intervened for appropriate coverage and payment where there was initial misunderstanding of the role of the house call clinician and the preventive service. And again, I would like to underscore how this reinforces the fundamental requirement to document the medical necessity and the in lieu of office visit for each encounter. So turning to the next slide, this provides in alphabetical order a listing of the preventive services and screenings now covered by Medicare, and again, each of them has their own certain situations. What I'm going to do is put together a chart of these services and list the applicable situations, the coding and payment levels, and some of that coding and payment may be from ancillary providers, and it may not be through your Part B services. Looking down this list, we also notice that some may be one-time services, some may be episodic, and some may be ongoing. Some may attach when the beneficiary becomes, when an individual becomes a beneficiary in the Medicare program, such as the initial preventive physical exam, for example, the Welcome to Medicare physical exam, being used within 12 months of becoming a Part B beneficiary. Others are more ongoing, such as the annual wellness visit, initial and that for the first time, and then subsequent for each year thereafter. So again, looking at this list, you may want to consider your patient population, your services capacity, whether you're working with others, what kind of team practice you may have, and what services you can arrange and provide within your practice to see if they are applicable for your practice from a capacity standpoint and also from a patient population perspective. I do want to go over a couple of the examples, just to a couple of these services, just to provide examples and to show some of the things that are pointed out in the various services. One of the broadest based and probably service that is used by Academy members, rendered by Academy members, is the annual wellness visit, including the personalized prevention plan initial. This would occur 12 months after the Welcome to Medicare visit if the beneficiary had one. If they didn't, they are still eligible for the annual wellness visits. And looking down the list of services that are required for you and content of the annual wellness visit, you can see how comprehensive it is, and it also reflects the development of sort of the plan of care, and the Academy has also recently put together a plan of care as a chapter in the field guide. And it's been observed that that plan of care and the annual wellness visit really reflect similar services and organization. At the bottom of this slide, I want to point out the coding for the annual wellness visit, first visit, and the national payment level is $166.44. The payment level in your particular MAC area would probably be plus or minus a few dollars from that. But that is the national payment level. Also want to indicate that if you were to provide a medically necessary encounter during the same time as the annual wellness visit, there is a mechanism to do that, and you would apply the 25 modifier to the evaluation and management code and submit both services. And that also creates an efficiency for the practice and for those services. Then the next slide, we have the annual wellness visit, including personalized prevention plan subsequent, and this can occur every 12 months following the initial annual wellness visit. Again, the coding is at the bottom, and the national payment level of $110.96. And once again, this can also be rendered in conjunction with a separately identifiable evaluation and management service modified with the 25. As another example of one of the prevention and screening services is tobacco use cessation counseling services. And this provides an outline for you of when CMS will cover the service. And I would want to highlight for you, you can see here in the first arrow point, when the beneficiary is competent and alert at the time that counseling is provided. So some of these counseling services share that attribute that CMS wants to make sure that the beneficiary is competent and alert for the counseling that is to occur. And again, so this is an aspect that we need to consider, particularly in a house call population. We can see that the counseling can be provided within the practice by a qualified physician or other Medicare-recognized practitioner, including our member nurse practitioners and physician assistants. This is the asystematic counseling service. There are also services when symptoms have been identified, but here I've also included the diagnostic codes to be provided in your coding for the asymptomatic counseling services. On the next slide, we see the G codes for this service, and again, the national payment level for the amount of counseling of 3 to 10 minutes of $13, and then the more extensive greater than 10 minutes national payment level of $28.25. And again, these preventive services are standalone services, and then there is the amount of activity that CMS will provide for up to these 8 sessions within a year. And again, they've also indicated that this service can be provided with a medically necessary visit. On the next slide, the annual depression screening that CMS has covered, and most of these services have been developed on a central basis by CMS through congressional direction. And one of the perhaps the benefits of how these services came about from a legislative history perspective is that they've been developed with the national coverage determinations, and so there is a uniformity to approach and should be a uniformity to application across the Medicare administrative contractors who are receiving your claims and making payment. We do have experience with the annual wellness visit and that service. We do not have a lot of experience within the Academy in terms of these other preventive services, again, owing to the fact that they are relatively new. And, you know, we're providing this, most of them are new from last year and even this year. And, for example, this annual depression screening isn't effective until April 2 of this year. So we will only know how the carriers are treating these services and whether they're understanding the house call in lieu of an office visit from your experience. So as you consider whether these services are appropriate to your patient population and to your practice and you know, professional capacity and opportunity, please let us know what you're seeing, including that you are getting paid appropriately for these services, and then also, of course, when there's any issues when you're not being paid correctly based on site of service or for some other reason. With the annual depression screening, I'd want to also point out at the third arrow there, sort of the integrative approach that they want to take with staffing and the referrals to mental health treatment as a result of the screening that occurs. However, in the next bullet, it's noted that the coverage is limited to screening, and it does not include the treatment options, you know, that result from the information you gather. And again, they have the time frame for when the service would be covered, and some of these services are time-based services. So you want to be when you're rendering these services, you want to make sure that you're really documenting not only the content, but also the time spent in the screening or the counseling, and then there it closes with the national payment level. Next slide is the obesity counseling, and we provide when beneficiaries would be eligible and providers would be covered and paid to provide this service with the body mass index indicated there. And again, we have the issue of competency and alert at the time that counseling is provided by a qualified physician or primary care practitioner. So we see that many of these services, again, are developed and described in the way that you can professionally render the services yourself. And then they provide the time frames and frequencies as we go down the page. And again, a time-based service and the national payment level indicated at the bottom. Moving on to the next slide, the screening behavioral counseling intervention for primary care to reduce alcohol misuse. And again, some of these services you want to consider your patient population, or again, maybe you're moving into a different patient population where these services maybe become more relevant and applicable. Again, we have the issue of patients being competent and alert at the time that counseling is provided, and you see the considerations for the misuse of alcohol. Again, a time-based service, and there is a screening and a counseling code, and these codes can be used separately, but at the time of screening, if there's a counseling session afterwards, they can be submitted on the same date of service. So that gives you a bit of a, hopefully that gives you a bit of an idea of some of the preventive services and some of the nuances of each preventive service. Certainly the testing ones where you're drawing specimens and sending them out to labs have their own nuances as well. And again, that may or may not be, it's part of your services, but it may or may not be part of your revenue stream. The services that you are rendering personally and professionally are those that do stay within the practice. Moving on and kind of shifting to a different topic of how we're trying to reduce some of the burden that's been experienced by practices and our members on a carrier-wide basis around the country. I want to talk about the medical record reviews and some of the initiatives that the Academy has underway, and provide you some of the context that is driving CMS's concerns and actually the increased volume of medical records reviews that's occurring not only in house calls but across specialties. One of the things that CMS is tasked with doing is improving their payment accuracy, and they need to reduce inaccurate payments, the amount of inaccurate payments, by $10 billion just in this calendar year. The Office of Management and Budget has designated 14, or has determined that 14 federal programs had high error rates historically, and with the last data being in 2010. 11 programs explain 94% of the errors in payment. 90% are overpayments, only 10% underpayments. 5 of the programs were within CMS, and they're listed there. Medicare Fee-for-Service, Medicare Part D, Medicare Advantage, and Medicaid, and the Children's Health Insurance Plan. The improper payments made by these programs themselves were $75 billion in 2010. So the error rate in 2010 is 8.6%. Was 8.6% out of the total program payments. You see that we're on the fee-for-service basis of $336 million. They want to reduce that by the 2.4%, and that roughly equals to $10 billion that CMS is tasked with reducing their inaccurate payments in this calendar year. And what CMS wants to move from is the pay and chase type of methodology, and that's why they're employing more data analytics and the idea of not paying the claim to begin with if they have any questions. And that's why we've seen some of these the increases in medical record reviews.